Representative Ballard, is that true? Thank you for your candor. All right, everybody. All right. Well, thank you. And thanks, everybody, for coming. Before we get started, I'll have a request for any bill introductions. All right, hearing none. We have two overviews today and a budget 101. Is that correct, Dayton? All right. Okay. So that's even better. So we have the two overviews today, and then we'll call it a wrap. So the first one I have, Secretary Howard is here from the Department of Children and Families. Secretary Howard, I think you're also the dual-hatted KDHE person. Are you going to slip into any of that, or?
That's, I think, the second presentation today for KDADS. The Department for Aging and Disabilities is my dual hat, so.
Well, Madam Secretary, thank you for being
Thank
here.
you.
For your situational awareness, there are 1, 2, 3, 4 new members to this committee. So, and including a new chair.
Yes, I recognize that. So, yes.
So
we'll try to stray from acronyms. So, yes.
All right. Thank you, Madam Chair.
Thank you. I appreciate the chance just to kind of give an overview before you all get kind of hot and heavy into the actual budget discussions. So I am Secretary Laura Howard. I'm the Secretary for the Department for Children and Families. Let's just start off our presentation with just a little bit of information about DCF on page 2, just in terms of our mission, which is around protecting children, strengthening families, and promoting adult self-sufficiency. And then I've included some of our values by which we do our work. I've included just an organizational chart on page 3. And I have a couple folks here I want to introduce that are with me today. First, I want to introduce Tanya Keys, have her stand up. Tanya is our Deputy Secretary for Programs, and so she is kind of our guru around our 4 main program areas. My Deputy Secretary for Operations is not here today, but you'll get to know Dan during the budget process. I also have with me Andrea Warnke, who is our governmental affairs manager, liaison. And so she's really the kind of on-the-ground person. So if you have questions, you have issues, you will see her around this building a lot, and she will bring those back. And we really do try to be responsive to the legislature. So you actually have her name and contact information on page 4, as well as our Director of Public and Governmental Affairs. But again, I think Andrew is kind of your key contact. And again, you feel welcome to reach out to any of us at any time, but I think you're likely to get perhaps a quicker response from Andrea, and she'll get it to the right person to get you a response. So at DCF, in terms of the organizational structure, we also have regional directors across the state. We have 36 regional offices, and I think also I would encourage you, if you don't have a relationship, we'd be happy to help you make an outreach to our regional directors. I think they can also be a really good source when there may be local or community issues that come up. So in terms of our organization, on page 5, we have 4 main programmatic areas that we do work in, and that's what I'm going to spend most of the time is talking to you about those and what those are, giving you a sense of maybe the size and scope and scale of some of those programs. But those areas are prevention and protection, which is really the broad arena around child and family well-being, kind of our traditional foster care services, adoption, some of our prevention, family preservation services. So the prevention and protection is our first bucket of area of focus. We also have a large area in what we call economic and employment services. DCF is the agency that carries out the administration of many of the federal direct benefit programs. That would include the CASH program, temporary assistance for families. That would include food assistance through the SNAP program, as well as a child care assistance and some others that I'll talk about in just a minute. And much of the work that we talked about on both of these is carried out through the staff that are in those offices across the state. The fourth area of focus we have is child support services. And then the last area of focus is rehabilitation services, which is vocational rehabilitation, really assisting individuals with disabilities or individuals who are blind or older blind with vocational support to be able to return to work. We also, under that rubric, are the entity under contract with the Federal Social Security Administration who does the disability determinations within the state of Kansas. We have a whole team of folks in a building in Southwest Topeka that is doing those federal disability determinations. As I mentioned earlier, we have those regional offices, 36 service centers that we've cut into 6 regions of the state, but 36 service centers across the state in various communities. All right, so I'll spend just a little bit of time on each of those program areas and just give you a few highlights in terms of what those areas of focus are. I will start with prevention and protection services. That's also the largest of our areas in terms of funding, particularly state funds. So as I said earlier, this really runs the range from prevention programs to foster care and adoption. And you can see on page 6, we are the agency that's responsible for investigation of child abuse and investigation of adult abuse. So our child protection services and our adult protection services, and we have a process by which we do that through our protection report centers, and then we investigate those. We also have responsibility to provide some front-end services, and this legislature's been, very generous in the last few years. Kansas is not, DCF is not an agency that had a lot of resources in prevention. Most of our resources were in foster care. We had some resources for the last few years in what we call family preservation, but through some federal options through what was called the Family First Act a few years ago, we really jumped on board very quickly, and the legislature's been very supportive in helping to fund those supports. So we've really expanded our prevention services, and we'll talk more about that. So a number of things in terms of front-end services to really try to support families in their communities and help youth stay at home, particularly when there's not an issue of abuse or neglect. We also are responsible then for the foster care system for those youth who have to come into custody. As well as adoption services for those youth whose permanency option ends up being adoption. We also provide independent living services for older youth in care who may age out of our system. And then we have a licensing responsibility as it relates to foster homes. So that's prevention and protection services. A little bit of a case load summary on the next page. So you can, I won't go through all of those. You can read those on your own, but you can see, for example, that in last year, we did almost 25,000 child protective service investigations. We did almost 11,000 adult protective services investigations. About 1,500 families were referred for family preservation. We have about 5,900 children in foster care, and that number's been going down. You'll see some charts recently that some of the front-end work we've been doing has really, really paid off in terms of being able to support children and their families. But again, just giving you some sense of the various programs within prevention and protection services. Obviously, as you glance down those dollars, you'll see that the biggest in terms of spending, continues to be foster care. With you see spending of almost $300 million related to foster care, about $50 million related to adoption support. In Kansas, we have a public-private partnership in terms of our foster care program. We've given you a map on page 8. We use what are called case management providers to do case management work. So as I talked about, we're responsible for the front-end reports of abuse, neglect, and those investigations. But when a child comes into care, We have a partnership with those case management providers who provide the day-to-day case management and determine those care needs for those youth. So you can look at the map on page 8. You can see that we have 5 case management providers. Some of them have more than one region. So we have St. Francis Ministries and kind of that purplish color on the left side of the state, that great big Region 1. We have St. Francis Ministries also in Region 2, coming over to the North Central region. So they have a really large chunk of the state geographically. KVC has 2 regions, one in the KC Metro for Johnson Douglas County area, and then Area 6, that would be Area 6, and then also Area 3, a little bit of that northeast region. We also have Cornerstones of Care in the Wyandotte, Leavenworth, Atchison area. We have, and then we have Ember Hope, who is a new case management provider since July in Sedgwick County. So again, you'll hear us say CMPs in terms of case management providers, and that's what that means. Those are our key partners in delivery of foster care case management services. They, of course, work with other partners in the child welfare system. You know, we have what are called child placing agencies that sponsor foster homes, and they work with those CPAs. Some of them also are child placing agencies, but when we talk to them as CMPs, we're talking about the larger case management responsibilities that they have. And again, we're a state that is more privatized than many states in the delivery of services in child welfare. Page 9, I alluded to this earlier in terms of children entering and exiting foster care across the years. You can see that for the since state fiscal year 20, we've had more children exiting care each year than entering care. And again, I think a lot of that has had to do with those front-end prevention programs that we've been doing, really trying to make sure that youth only come into care if they really need to do so for reasons of abuse, and if families can be supported in the community, the children can stay there safely, that we can support that. So again, that tells you the entries and exits. If I had a slide just of totals, I mean, a number of youth in care has gone down from about 7,600 beginning of this period to about 5,600 today. So. In terms of success stories with this kind of first bucket of services, we always do like to talk about Family First, which are the prevention services that we began in 2019. The federal government passed a law that allowed states to begin using certain federal child welfare funds for prevention services. Before, those funds could really only be used for foster care. So they also had to be used for evidence-based programs in 4 categories: mental health, parent skill building, what's called kinship navigation to maybe help families who maybe might be trying to do a guardianship or things like that through some legal services, and substance use disorders. A chief measure of this success, of course, is the percentage of children who are able to remain at home safely. So we measure that, and since the program's inception, 89% of children and youth who've reached 12 months from the time of referral to that program have remained at home safely. We've hovered around our program goal of 90%. It might be 91% for a few months, might be 89%, but again, very, very high rates. For kinship navigation and mental health, we're actually at 100% and 90%. So again, these have been very effective programs. These are grants that we entered into with a number of entities. For example, parent skill building could be things you're already familiar with, like parents as teachers or other kinds of home visiting programs. There's a variety of mental health programs, including functional family therapy or what's called multi-systemic therapy, and then some specialized substance use programs. So again, it's been very successful. We've been, you'll probably see more slides about this when we present later on that give you a little bit more of the quantitative detail. But again, very good success, and you really see that playing out as you look at our numbers in foster care. The other success story that that we are very excited about. It comes from work that this legislature did last year, where Kansas created a new permanency option for youth called the Sole Family Legal Permanency Option. Before this, like most states, when a child was in care, their permanency options might be returning to home, which we called reunification, could be adoption if the child couldn't safely return home and parental rights were severed, could be a guardianship or custodianship, or they could age out of care with no permanent connection to an adult. This is a new option. We were the first state in the nation to do this. It was really designed in partnership with the Casey Foundation and really use the voices of folks who really had lived experience in our system to say, we think that there are other ways to establish caregiving relationships with adults without having to sever our biological families and to still be able to access some of those independent living benefits. So it's called Sole Family Legal Permanency, Support Opportunity, Unity, and Legal Relationships. Since the effective date on July 1st, we've had multiple sole family legal permanencies. I'm not sure what number we're at now, maybe 6 or 7, 5, 6 or something like that. And again, really proud of that and proud to be the first state to really listen to youth and provide an option that's going to give those youth the chance to have a connection to an adult as they move to adulthood without losing some of those supports or benefits they would otherwise have if they aged out. So excited about that. So that's the first bucket, and kind of the biggest one in DCF in terms of state funds especially. So prevention and protection services. The second program we administer is child support services. And our director of child support services is Marcy Martinez. So child support, obviously helps children receive the financial support necessary for their growth and development. So we're involved in establishing parentage and orders for child support, locating those non-custodial parents, enforcing child support orders, and modifying support orders as needed. It's a large constellation when you think about the income support there, in terms of annual collections of about $200 million on behalf of 122,000 families, or about that many average cases each month. We've given you some information about the Child Support Services Center. This is also a program that we do through private contracts. We have 2 what we call full service contractors who do all of those kinds of services that we just talked about. And then in addition to that, there's also a payment center that does the processing of those payments. Those 2 full-service contractors are Maximus Human Services and Young Williams. And you can see a map on page, what page is that? 14, I think, that will show you kind of who has what regions. Maximus really has kind of the largest metro regions in terms of the KCK region in Sedgwick County, and then Young Williams is serving the remainder of the state. So we don't talk about this program as much as others. It really is a direct, but if you think about direct supports to families, it's the most impactful program we have. We talk a lot about the direct benefits that we do through TANF for food assistance, but the ability for children to get child support that's due and owed to them through valid court orders and to get those established and enforced is incredible when you think about the amount of resource then that's going to families through that process. The third area of that third of the 4 buckets is economic and employment services. Our director of economic and employment services is Dr. Carla Whiteside Hicks. This is the area of our agency that I think you would think of as maybe the most traditional in terms of public human services, or what we might have in the past called public welfare programs. These are a lot of programs that help families achieve self-sufficiency. So we have the cash assistance through the Temporary Assistance for Needy Families program, which many decades ago was called AFDC, if anyone here remembers that. Some people might not have been born yet when that was, anyway, I'm old. The second is food assistance, where we administer the federal food assistance through the Supplemental Nutrition Assistance Program, or otherwise known as SNAP. The third is child care assistance for eligible families. And then we have a wide array of employment assistance that's attached to those programs. So individuals who are receiving food assistance or TANF get employment supports to help them gain employment or increase their employment or gain additional skills. And so it's a focus not just on the assistance, but on the self-sufficiency side of it. We also have some programs that are maybe more short-term. There's an energy assistance program called the LEAP program that we do each year. It just opened up a month ago. It's just during the winter season, low-income energy assistance program, and that really helps to pay for, those heating bills. We work with the utility companies and individuals on behalf of those individuals who may not have resources to keep the heat on. So again, that's also a federal program that we administer on a seasonal basis. And then there's a new emergency water assistance program that the federal government started in some legislation a couple of years ago. That's a brand new program, and again, designed to help folks not lose access to their water. That's a much smaller program. Again, I wanted to also just give you a sense of the context of these programs. If you look at this on page 16, a little bit just about size. Our TANF program, as TANF is a block grant that's given to states that's been around since the late 1990s, when what had been an entitlement program was turned into a block grant. Kansas gets about $104 million a year for TANF. You can use that on cash assistance. You can use that on grants that meet certain family needs. You can use that on employment. On the cash side, Kansas spends about $10 million, maybe a little bit less than that, on cash assistance. We serve about 7,200 individuals. And part of that really relates to the eligibility requirements that are in place in Kansas. If you looked at this program, 10 or 15 years ago, we would have been serving a much larger number of individuals on cash assistance. But through what was called the HOPE Act that was passed a few years ago and amended a couple times, there were some shorter time limits put on the program and other restrictions to access that program. So we're not a state that spends a lot of TANF on cash benefits. So again, only about 7,000 Kansans, accessing those cash resources. Again, we also have spent some of those resources on employment services related to those individuals. Again, a fairly small part of our budget. The LEAP program, which is a federal program, you can see in fiscal year 24, served about 85,000 people, about $59 million to help keep that heat on. I'll go on to SNAP. This is the biggest program on this page. This is food assistance. You can see about 190,000 Kansans have access to some portion of SNAP assistance. And depending upon the year, $400 to $500 million. I would make a comment, just since this is a budget committee, that those are 100% federal dollars, those food assistance dollars. We have to pay 50% on the administration side, but that line actually doesn't show up in the state budget at all. It's an off-budget item, or else our budget would be like $500 million greater than it is. But again, those are real benefits to real Kansans. I mean, a significant impact for those individuals, as well as just the impact on the economy of those resources going in to buy groceries and those things. Then some of the employment and training related to SNAP. Child care assistance is the other main program in terms of assistance. We provide subsidies to about 13,000 children towards their child care. And again, all of these programs have different income limitations or other requirements. And we didn't put all that detail in here because it's pretty complex, but we're happy to share any of those details with the committee. So there's a child care subsidy where children can go to providers who have applied to receive subsidies from DCF and receive some offset of all or a portion of their child care costs, depending upon family income. And we also run the Kansas Early Head Start program for young children, younger than those who would be in Head Start. And again, that's done through, a number of local partners as well. But again, just giving kind of a context of those totals, most of the dollars on this page are federal funds, and except for within kind of like childcare and early Head Start, where you have kind of a mix of dollars there. So, in terms of success stories, I think within our DCF work programs, we always like to report, what some of that progress and those outcomes have been. TANF cash assistance adults who are required to engage in work programs. If you have certain disabilities, or maybe you have an infant, there's reasons why you might be exempt for a period of time. But if you're required to participate, you have to participate in 20 to 30 hours per week in work programs. And we did under TANF, we had 939 new employments from July 23 to June of 24. We also had another program, and we've kind of merged a couple of these together. We called the Goals program. That was kind of a pilot program, and we've got some employment data there too. And then through our food assistance, able-bodied adults on food assistance who don't have any dependents are required to work to meet employment goals in order to receive SNAP. There are federal rules around that, and then there are state rules around that are a little bit more stringent than the federal rules. They're pretty close now based on some things the federal government did recently. So again, those are some, just some success stories there in terms of some of the work programs. The last two actually relate to the last part of our agency I'm going to talk about in just a second, rehabilitation services. But through vocational rehabilitation, helping those individuals with disabilities return to employment. We had 970 individuals achieve competitive employment last year through that process. And then we also work with youth with disabilities as they're getting ready to leave school to do what we call pre-employment and transition services, really helping them to think about their future, do job counseling, education counseling, and the like. And that all relates to the fourth area that I was going to talk about next, which is the rehabilitation services. That's led by Dan Decker. And again, this is a variety of programs to meet needs of Kansas with disabilities. We fund the vast majority have to do with vocational or employment services. We have some resources around independent living and provide some funding and supports to independent living centers across Kansas. We also provide services for older Kansans who are blind or visually impaired. And then, as I said earlier, we conduct the disability determination services on behalf of the Social Security Administration. So in terms of caseloads here, our voc rehab caseload, those individuals with a disability trying to return to work, about 7,200 Kansans with disabilities, about 6,300 average monthly persons, with 970 achieving competitive employment. So we continue to have successes there, and and some of those individuals, they might be going to school towards what it is they want to do. Just different things that are going to help individuals who often have encountered a disability. Maybe there's an accident that's left them, with some amount of paralysis or things like that, and just how to help folks re-enter the workforce. So, and then the disability claims. We processed 27,000 disability claims with a 98.9% accuracy rate. Kansas has been recognized by the Social Security Administration for really as long as I could remember for our accuracy rate on those disability claims. It's been always in that 98, 99%. I'm really, really proud of that because, I sat there a few years ago with a worker who does that disability determination work. It is really hard and really complex. You're looking at a lot of things that have to do with medical data and all sorts of things. It is not easy work. And when you think about all the numbers of appeals that might happen for people who are denied those things, to be able to have that high of an accuracy rate the first time is really, really good and good for Kansans. I know you'll be getting more into the details of budget next week, but just from a context piece, I just gave you just a couple slides in terms of the overall DCF approved budget last year. So nothing about the new things we'll be talking about in next week. But a total budget of just under $1 billion, $972 million. Federal funds are about $481 million of that. The basic state general fund dollars are $463 million, a little bit of other things through some other state funds. So pretty close to, a little bit more federal funds than state funds, but pretty close to half and half state and federal funds in our budget. And then just a context piece. If you look at the next two slides, the first next slide is from all funding sources, that $972 million. So this is state and federal dollars. Again, you can see the largest amount of our expenditure by far is in our prevention and protection services area, that child welfare and prevention services, followed by the economic and employment support area, and then a lot smaller spending on rehab and child support services. And then the last page related to funding just looks at only the state general fund. If you're just looking at that, and again, that prevention and protection services is certainly the largest proportion of our state general fund dollars. So again, just to give a context, so a lot of our benefit programs are very, very federally funded. You'll see that on the third budget page, where our largest federal funding is child care, followed by foster care and adoption, followed by TANF. So, and again, that's because those food assistance dollars are off budget, or it would be like taking this chart out way past the window with $500 million on it. So, all right, that was kind of a quick overview. We do have 3 priorities that we hope to work with the legislature on during this session that I think will get introduced next week. They're all in the child welfare arena. First, we will have a bill to reduce the number of days a child in the custody of the secretary can be authorized for a secure care locked placement by a court from 60 to 45 days to make that parallel to what the rules are around kids in the juvenile justice system. We also want to reduce the timeframes within which permanency hearings have to be held for youth who are in foster care. This says sync permanency hearings. If you're not familiar with that term, that means child in need of care under our child in need of care code. So these are youth who are in the custody of the secretary in the foster care system. We want to reduce that in order to reduce the amount of time that youth are in care. Youth are in care too long in Kansas compared to some national averages, and we think that's one thing that might help that. And then the last one I think I'm kind of most excited about is making some changes again in the child in need of care code that really have to do with the current definitions of neglect and making sure that we're not separating children and families solely due to poverty and things that aren't about abuse. So again, more to come on those. We'll probably be introducing those, I think, next week in the House Child Welfare Committee. So I'll stop there and answer any questions.
Madam Secretary, thank you for that. Committee, questions? Representative Carpenter?
Before I take up the whole meeting, I wanted to make sure that everybody had a chance to ask questions first. No, I don't have very many questions, but I could. So what is our balance on our unemployment or our child support owed at this point in time?
I'll have to get that back. I'll get that back to you when we're back here next week. I don't have it in my head. Yeah.
It's about around 900 million.
Yeah, I mean it's been in the range of 850 to 950 in terms of uncollected child support. Yeah.
This one.
Yep. Yeah, but I'll check that and get the numbers back to folks.
Very good. Thank you.
Representative Ballard?
Thank you, Madam Secretary. I will just look at one of your 3. Secure care placement, reducing the number of days. I can't remember how many days we had, and why were we reducing them?
Yeah, this is really about You know, what's good for youth? So right now, a child in my custody could be authorized for a secure replacement, and there's one provider in Kansas. It's in Geary County. I'm not being critical of the facility, but it's essentially like being in a jail setting, right? And so these are for kids, maybe who might have been on the run or things like that. And so this is trying to reduce the number of days that could be authorized from 60 to 45. That's what was done when juvenile justice reform happened. You're saying that that's not the best setting for a youth, that we need to find other options to keep kids safe. And so again, we're trying to come in parallel to what was done already in the juvenile justice code. So. I mean, I'd actually love to eliminate it altogether in child welfare, to be honest, but I felt like a good place to start might be to say, let's have parity between what we did under juvenile justice reform, and that why would we have a foster youth in this setting longer, who, isn't in the setting related to, some charge they have or things like that. So, yeah. Not specifically. I mean, I think it's a really good question, Representative Ballard. I think much of the work that we've been doing around trying to grow, for example, more specialized foster homes, like therapeutic foster homes, we're up to 31 homes there that have a capacity for 62 kids in the therapeutic foster homes, and just some of the other initiatives that might bring more supports to foster families, bringing more mental health supports into the home through some of our work around adding behavior intervention services. We added that to our state Medicaid plan for a state to do that, to provide in-home services to our foster youth. We also have a new pilot that you hear about with our budget to create some more intensive, smaller caseload with regard to our case management providers, to have like 1 to 5 cases to provide more support to certain foster homes. I think all those things are the sorts of things when you have youth with challenging behaviors. You have to build that array of supports that can make sure that that a home that wants to take a child in has the supports they need to be successful in doing that, and that the child has the supports that they need. Yeah.
Okay, thank you. Representative King?
Secretary.
Thank you.
And I'm new to the committee here, so if this is questions that I'm asking today that are going to be covered next week, please let me know. But I'm curious on the fiscal year 2025 approved budget by program. I think that's like page 20 or so. The $1 billion there, about how much of that goes to the private contractors, and about how much of that do you keep, I would say, in-house and that you spend on your own employees and all?
Sure. And it's easier, we can get you some more details maybe next week on like what the actual amounts that go to our contractors in terms of what's actually for case management versus the actual services for youth. But in terms of, if you look at the way our budget talks about on that page, and let me see if there's a better page, where you can see where we talk about kind of spending around administration. So I might go back to the approved budget by program that's not SGF. So where we talk about $18.7 million in administration, and then if you look up a few more lines, regional service delivery, about $122 million. Those are all of the staff that are in our regional service centers that are doing all the benefit determinations for people. Most of our staff are out in the regions. A much smaller proportion is here in our central office. So that gives you a context just of what you would think of as direct, DCF administration, or what we think of as the service delivery. And then we'll have a little bit more detail next week that would let you see like how much goes out to, like, say, case management providers and those things. So
That'd be helpful.
Yeah.
And then also the number of employees that DCF has, and then also the number of contractor employees. So how many boots on the ground do we have total, would be just an interesting point for me anyway.
Thank you. We'll see what we can do on that one. I know our presentation next week has the FTE that we have. We'll see what we can do on the other side.
And then my last one would be the information technology, the 60 to 63 million there. And one recommendation that I've had from a constituent was if the boots on the ground people, whether it be the contractor or your people, would have tablets, that the information could be entered into while they're in the home setting right then on the tablet. It's into the system, and we try to eliminate as much paperwork and back and forth and phone call time as possible. I just bring that up as something that I heard. Thank you, Mr. Chairman.
Yeah, thank you. I've definitely heard that before, and I think there's even been a little bit of piloting of that in one of our program areas in one of our regions. We have very antiquated information systems, as those who've sat on the committee for a while know. We're pretty excited that I always say this when I'm at the podium, but we really are almost ready to announce the contractor for our new comprehensive child welfare information system that will bring together, 7 different systems and also have our contractors, those case management providers, be on the same system. That will be a game changer as that gets implemented over the next couple of years. So.
I think we have one more. Representative Rivas?
Yes, thank you for your presentation. Just an observation back on page 7. The adult protective services investigations went down, but the assistance cost went up significantly. So are the investigations and the assistance directly tied together, or are those not exactly connected?
Thank you for the question. That's a really good question. Not directly connected, but I would say the reason that amount went up is we put a little bit more money in for assistance. On the Adult Protective Services side, we really have had very little money in our budget to actually provide any sort of supports or services for things we might find in that investigation, right? And adult is different than children. Children, they might come into custody, you might put supports in the community. Adults have decision-making authority, so it's a different situation. But for example, we didn't have, say, a lot of resources. Say we needed to move somebody to help them move to an environment that was safer. Maybe they were in an environment that, I don't know, was full of bed bugs, or they were with a person who had been an abuser and they needed to be in a different setting. So we actually added a little bit more resource to our budget, so there'd be a little bit more of that flexible funding to try to meet some of those needs on the adult side. So I don't think I would attribute the change there to anything more than that. So. Yeah.
Trend that would continue, or is it at a level now that it can kind of maintain a more even?
I would expect we'd maintain it at this level now. We didn't request any additional funding in our budget for that for this year. I think we want to kind of see how this goes. There's a lot of partnership that happens. There's a lot of community resources that come to the table in that. But it was just those situations where if you could spend, just a few $100s right now, you could get a person out of a dangerous situation and help them, be in a more stable environment. So.
Thanks for that. Could I ask one more?
Go ahead.
Kind of a quick follow-up to the contractor questions that Representative King had. So earlier you mentioned the contractors that do a lot of the child support collections, I guess, is that what that is?
Yes.
So when you're back next week or whenever, can you expand a little bit on that? As why is it worth paying for a contractor versus keeping things in-house, and just kind of give an overview?
Sure. Yeah, and that happened over a period of time. I can talk more about that next week in terms of, we had always used contractors to help with some things like, establishing paternity, things like that, maybe some help with collections. But there was some state policy decisions made a few years ago to go to what we would call kind of full service privatization. So DCF did used to have, not large, but certainly a child support staff that had a couple hundred people, and now it's just very small in terms of just an oversight function. But I can expand on that as needed next week.
Cost benefit side would be great.
Thanks.
Thank you, Madam Chair.
Thank you.
I see no other questions, so I'm assuming you're not doing the next one. Am I correct?
I'm going to start the next one, and then I'm going to hand it off. So,
Sounds great.
Yeah, let me get the right file. Be right back.
Smoke them if you got them. Sorry.
Thank you, Mr. Chairman. So now I appear, Laura Howard, on behalf of Department for Aging and Disability Services. And again, we'll do kind of a similar presentation, really trying to get just an overview of what the Kansas Department for Aging and Disability Services is, what the programs are we administer, some sense of the scope and scale of those things, and also just what some of maybe the key current activities and priorities are. I'll start out just with the overall organizational chart, and I won't go through all of this chart, but I do have 2 deputy secretaries at KDADS, and they'll do some presentations in just a minute. So the first is Scott Bruner is in the second row. He is our deputy secretary. He has responsibility over our state hospitals and over the survey and certification functions. And then Andy Brown is our deputy secretary for programs. So he has responsibility over our behavioral health programs, aging programs, what we call long-term services and support programs. And again, we'll go into more detail, or they'll go into more detail about those programs that they oversee. I also have with me today Lee Keck. And on the next page, you actually have her picture and phone number and email. Lee is our Director of Governmental Affairs. She is kind of the one on the ground here. And so if you need anything from us, reach out to Lee. Does a great job for KDADS. And again, anything you need, just kind of reach out to her and she'll make sure it gets to the right person. And again, that doesn't mean you can't call any of us. I mean, some of you who've been around know you kind of have us on speed dial, so you can call me or my deputies too. But Lee is a great person. And also, even if you have a constituent request, that kind of thing, she'll make sure that we get that to the right place. All right, so I'm going to just do a couple of overview slides before I hand it off. Just on the next page, just wanted to kind of have a quick map that shows you where our state hospitals are, and Scott will talk more about this when he talks about the State Hospital Commission. But we have 4 state hospitals in Kansas. 2 of those are psychiatric hospitals in Osawatomie on the eastern side of the state and in Larned. Then we have 2 hospitals for persons with intellectual and developmental disabilities here in Topeka at what's called Kansas Neurological Institute, and then down in Parsons. And we've given you the names of the superintendents at those hospitals. So, and those are separate budgets. I think you're doing those budgets next week, but we do have oversight of those facilities. Just a quick context in terms of budget. If you look at page 5, you can see in terms of, actual spending in KDADS, you can see just over $1 billion in state funds, about $1.8 billion in federal funds, so really about $3 billion as an agency. We're a big Medicaid agency. You have the Department of Health and Environment budget. They are the official single state agency for Medicaid. They manage the CanCare program, but we have the largest areas of funding in our budget are Medicaid-funded programs, including the funding for nursing facilities and including funding for what we call home and community-based service waivers that Andy will talk more about. So in the aggregate, those make up a huge chunk of our budget. And I always like to say that because folks, think of KDHE as the Medicaid agency, but, we've got, more than $1 billion in Medicaid funding in our agency. So, in terms of positions, just to give you a context of positions, you can see some things broken out by our various commissions on the next page. And what's called the SCC Commission, the Survey and Certification Commission, we have some central office people, but then those are primarily the folks that are across the state doing surveys of nursing facilities and other healthcare providers. So they're kind of out in the field. The rest of the folks are, primarily here in Topeka. And obviously this doesn't include the positions at the state hospitals. You will see those in the state hospital budgets. And then last couple slides before I hand this off, you can see the vast proportion of our budget is on the aid and assistance side. Smaller expenditures in the salaries and contractual area, and the vast majority is that aid and assistance. Again, whether those are nursing home benefits, whether those are individuals receiving in-home services through one of those home and community-based services waivers. And then again, the next page kind of just shows you, the last one I'll talk about, just shows you expenditures by program, and you can see what we call our Medicaid program, the largest in terms of expenditures. So again, just to give that context, and we will go into more details on budget next week. So I'm going to have my deputy secretaries talk about the major program areas, starting with aging services, behavioral health services, and long-term services and support from Deputy Secretary Brown, and then Deputy Secretary Bruner will talk about State Hospital Commission, Survey and CERT, and some of our priorities this session. So, very good.
Thank you, Madam Secretary.
Thank you, Chair. My name is Andy Brown. I'm the Deputy Secretary for Programs at ks.gov. I'm going to start with the Aging Services Commission on page 10. So our Aging Services Commission was sort of reestablished last year. We've accomplished a lot, I think, in our first 12 months, and we're looking forward to our next year. The Aging Services Commission works on the Older Americans Act, Senior Care Act, our Senior Nutrition Program, and our PACE program. And then we also have a group that works with nursing facility programs on things like regulations, gatekeeping, and our quality assurance programs. So as far as our priorities and accomplishments go for aging services, there's quite a list here, so I'll cover a couple of those, but we're really proud of the expansion that we've been doing with our PACE program, which is the program of all-inclusive care for the elderly. We've been able to really make some progress on that in Johnson County, and we're also getting ready to put out some expansion grants as well. We've also been working to really try to enhance assistance to Medicare beneficiaries and healthcare providers regarding fraudulent Medicare activity, making sure that people are aware of those and protected against them. And then we've been working to reconvene the Advisory Council on Aging, and we're looking forward to getting some legislative appointees to that council. So if you're interested, let me know. We also have begun work on our next 4-year state plan on aging. We've been doing listening sessions around the state with our AAAs, and also working to put together an advisory group to assist with that. For the Behavioral Health Services Commission, this is our commission that works closely on issues like mental health and substance use disorder programs. There's a number of other things that it does as well that are related to behavioral health, like problem gambling and drug and alcohol prevention work and tobacco enforcement. Primarily, we work with our community agencies to provide those services that you saw on a previous slide, which are really direct services across the state to folks that are either uninsured or possibly Medicaid recipients. And then our SUD program services are very similar. We work with a group of providers across the state to make sure that there's access to those types of services for the same populations. As far as priorities and accomplishments for the Behavioral Health Commission, again, this is a pretty long list, so I'll just highlight a few of these, but we're really proud of the work that we've done around 988 to expand the National Suicide Prevention Lifeline. We've been able to make quite a bit of progress on our CCBHCs, which are Certified Community Behavioral Health Centers within the CanCare program. And we were recently able to launch the CMS demonstration for the state of Kansas on January 1st. And then we've been expanding our assisted outpatient treatment program to multiple sites, including Cowley, Douglas, Ellis, Ford, Riley, and Sumner counties. And we're currently maintaining a 97% reduction in recidivism among graduates of that program. And then we're continuing to expand our provision of medication-assisted treatment, or MAT, among our SUD treatment programs. And there's a lot of exciting work that's happening there across the state as well. For Long-Term Services and Supports Commission, this is our commission that works on the HCBS or Home and Community-Based Services waivers. There are lots of different types of waivers, and we'll go over some of those in more detail here in a second. But we also work with the ADRCs, or the Aging and Disability Resource Centers, and the Administrative Case Management Program. So we work closely with community-based partners, including the CDDOs, home health agencies, and providers of disability and brain injury services. On page 15, you can see a list of our HCBS waivers. We have the autism waiver, frail and elderly waiver, the IDD waiver, which is intellectual and developmental disability, our physical disability waiver, our serious emotional disturbance waiver, or SED waiver, which is children with emotional disturbances, and then technology assistance and brain injury waiver. And the brain injury waiver is a rehab waiver, so folks that are on that waiver tend to come off of it relatively quickly once they've been through rehab. And so then on page 16, for each of the waivers, there's a list of the number of people that are eligible to receive services, as well as the number of people that are on a wait list, if that waiver has a wait list. And then also there's a list of proposed recipients for autism. On page 17, this is the list of priorities and accomplishments for the LTSS Commission. So a lot of work has been happening here, and this commission's a very busy commission. In addition to a number of other things, we've been working on the HCBS settles filing rule compliance, which I'm sure many of you will hear a lot about this session. We've also been working to renew our IDD waiver and brain injury waivers. We were able to do that successfully. We created waiver amendments that allow for paid family caregivers and telehealth options. We made offers, thanks to the legislature, to 500 Kansans for each of the IDD and the physical disability PD waivers. And we're working towards our application to the Federal Centers for Medicare and Medicaid Services, or CMS, for a new community supports waiver. And that's really designed to provide less intensive services to individuals that are on the wait list for the IDD waiver and help reduce the number of people waiting for services there. Page 18 has some information about our FMAP enhancement projects. Not a lot of detail to give you there during the presentation, but we are working to make sure that those funds are utilized in the best way possible during the coming year. And then on page 19, this is around the Special Committee on Targeted Case Management. This committee met most recently, I believe, on October 9th to review changes to the targeted case management in the Intellectual and Developmental Disability Service Network, or the IDD network. And there were a number of bullet points here that we reviewed. The final settings rule, which was issued in 2014, has guidelines around the mitigation of conflict of interest, including targeted case management. We're currently under a corrective action plan with CMS to try to remediate those issues around conflict of interest with targeted case management. And we've been working with providers to gather input and to look at granting opportunities to transition business models in order to mitigate conflict of interest. So we have lots of modernization efforts that are currently going on. We have a terrific summary of all of that on our website. And I'd encourage you to reach out to Lee or I, or even our Commissioner, Michelle Hayden, with questions that you have around that, as I'm sure you'll hear a lot about it this session. And I will go ahead and turn things over to Scott at this time.
Thank you. We'll hold questions until Scott, Deputy Secretary Bruner, finishes, and then if that's okay with you gentlemen. Okay.
And Scott's fine. My name's Scott Bruner. I'm the Deputy Secretary for Hospitals and Facilities. I'll finish up the presentation on slide 20. So the two commissions that I oversee, the State Hospital Commission and the Survey Certification Commission, start with state hospitals. As the Secretary said, we operate 4 state hospitals in the state of Kansas, 2 for people with mental illness and 2 for people with intellectual and developmental disabilities. You're going to hear our budgets next week on Wednesday, and the superintendents will be here to talk about their programs, so I don't want to take any of their thunder and what they'll want to share. But what we do at the ks level is provide operational support to all 4 of the hospitals. We oversee the superintendents directly through our commissioner, to make sure they have oversight in what they need to get from central office resources, either IT or capital improvements, because the campuses are large. We have lots of buildings, and all of that capital improvement spending flows through KDADS. The other thing that we've tried to do at the commission level is make sure that we're supporting the hospitals as they're trying to maintain their CMS certification or credentialing, so they can keep drawing federal funds where they can for patients that are eligible for those. That takes effort on the campus, but we're also able to provide some support from the central office level as well. And then probably the last thing that we do, and it shows up in some of the priorities and accomplishments, there are just some projects that will benefit the state hospitals that they just don't have the capacity or time to work on and provide resource to. So what we've tried to do over the last 6 years or so is really bring some additional support and capacity to the campuses clinically, IT, at the IT level, capital improvements, and just programmatically to kind of do some things that benefit all 4 campuses. So on page 21, just as an example, or a few examples, the second bullet point, one of our issues over the last, well, I think as long as we've had state hospitals, is the rate of pay for our direct care staff. So we serve 1,000 patients a day across the 4 campuses. That requires nurses and doctors and other kinds of clinical licensed folks, but also a good number of people who are direct care workers who are working with our patients to make sure they have their needs met in therapy. And before, maybe 3 years ago, their level of pay was not high compared to other people you might see working in a nursing home or a hospital. So we've made a lot of efforts to try to raise those pay rates to make them more competitive through executive orders during the COVID pandemic. We also had some specialized programs to address 24/7 facilities and try to raise those pay rates. And last year in the budget process, those were rolled into the base pay rate. So we've made a lot of progress over the last 4 or 5 years in pay rates. And even last year, you authorized us to have some additional flexibility in paying bonuses for sign-on, picking up extra shifts, things like that aren't legal for other state employees, but we've been using that flexibility to try to address some of our staffing issues. I'll come back to competency because some of you heard my competency pitch in the Health Committee, but other kind of general projects we've been working on as a commission to help is the electronic health record. We've had our mental health hospitals at Larned and Osawatomie had electronic health records, largely homegrown systems, but at Parsons and KNI, we've been on paper since they started operating. And so one of the projects we were able to do as a system was bring one statewide electronic health record that serves all 4 campuses. And after 4 years or so, as of Tuesday, we're live on all 4 campuses and operating. We're really excited about the possibility getting everybody through the kind of transition and growing pains of learning a new system and transitioning from what they'd been used to, but then also kind of standardizing some processes, standardizing how data is collected so we can look at that at a commission level and really put that to use. So it's a huge accomplishment. A lot of credit goes to the campuses and our team and our IT team to make sure that's happened. We're building a 5th hospital. I guess we're so good at it, or we need more capacity in our system. We'll talk more about that next week. But we are building a 5th state hospital in Sedgwick County to serve the psychiatric patients in that area. Can talk more about that in just a second. And then one of the other things, because our state hospital at Larned is the state security hospital, we have a role in determining competency for criminal defendants around the state that aren't able to understand the gravity of their offenses or can't participate in their defense. So if a court has an order or a judge decides that a criminal defendant doesn't understand or isn't competent to understand the charges against them, they're ordered to Larned to be evaluated, and then if they're incompetent then or determined to be incompetent, we try to restore them to competency so they can continue their criminal process. That's created backlogs. Larned's great, does a lot of work, but the number of defendants well exceeded our capacity to serve all of them. So we've tried a number of different initiatives to try to extend the reach of Larned to communities, work with community partners to do those competency evaluations and restorations. And the slide describes that. We're working with community mental health centers with some additional funding from a couple years ago to have them do competency work in jails. We're also, because of the wait time, and so those defendants are sitting in county jails waiting to come to Larned to have that next part of their criminal process continue. A couple of years ago, you authorized us to pay $100 a day to counties for the time that somebody's waiting from when they're ordered until they're admitted at Larned or their competency's been determined. And we'll bring some data next week about what that's looked like. So a lot of work around competency that is related to state hospitals, but a little bit off the campus as well. Then the other commission that I oversee is survey, certification, and credentialing. These are the regulatory functions that are under the KDED's umbrella. We work to protect public health through inspection and licensing of adult care homes and providers of disability and behavioral health services. Most of the work that we do is under the authorization of the federal government. So we're surveying nursing facilities on behalf of the federal government. But at the same time, we're also enforcing state regulations for other care settings like assisted livings, home pluses, and a number of other providers of services that receive a state license from us, and so we provide oversight to those as well. We do that through investigating complaints about abuse and neglect. We get complaints through our hotline. Some are referred from the Adult Protective Services at DCF that you've already heard about. We go out and investigate those things, and we do some that are more routine surveys as well. And then at the most extreme, if we find a facility that is not able to meet the needs of their residents, we do have the authority to assume temporary management of nursing homes and then try to bring them back into compliance or get them onto another owner. Over the next couple of slides, we're trying to provide some context of what that regulatory role looks like. So on slide 23, our abuse and neglect hotline received almost 7,000 calls in 2024. And we put the number of FTE that are assigned to that unit and how many are vacant, so you can kind of get a sense of how many people are doing this work. We have 551 facilities that are state licensed only, so they operate only under a state license. Those are things like residential care facilities, home pluses, assisted livings. And then there are 308 nursing facilities in the state. Most of those are also participate in the Medicare and Medicaid program, and so there's some federal authority that we're overseeing as well. But so between those two, there's 850 or so facilities that we're in surveying to make sure there's quality of care and they're following state guidelines. In terms of the service providers, so we also write licenses for people who provide substance abuse services, behavioral health services, IDD services, and you can see the numbers there of providers that we license. Often these aren't physical locations necessarily. They're the service provider, and they can operate in multiple locations. So it's a little different than a brick and mortar place, but we still try to oversee it or work on a lot of the same standards in terms of documentation, quality of care, making sure people are free from abuse and neglect, those kinds of things. And again, the number of FTE of people that are assigned to that are on there as well. And then on slide 25, the last part of the commission is our health occupations credentialing. So we license buildings, we license service providers, and then there are also some health professions that we're the licensing body for them as well. So that includes certified nurse aides, so people who work in nursing facilities providing direct care to residents. That's a federal certification that we oversee and write the certifications for. Certified medication aides is another category that's on that certification box on the right-hand side. Home health aides as well are licensed by us. Then there's a few other license types that we're responsible for that are a little surprising or not ones you'd expect. But adult care home administrators, that one's probably not so surprising, but we license adult care home administrators, speech language pathologists, dietitians. That falls under our health occupations credentialing activity as well. And the largest part of the HOC team is involved in criminal background checks. So all of these professions that I talked about, all of the kinds of work that happens in licensed facilities has to be performed by people who are able to pass a criminal background check. So we process those and let employers know who's qualified to work in those settings or not based on any potential criminal background check. On slide 26, a few of the accomplishments for that, the survey team. We work a lot across our commission, so what Andy oversees are the policy side, come up with the great ideas and the services that they want to provide, and we provide the regulatory structure behind that to make sure people are meeting standards and we're in compliance with state regulations and federal regulations where required. We've completed the sale. We went through about 5 years ago, I think, a group of nursing facilities that were no longer able to operate, and they surrendered themselves to the state to be taken into receivership. And so over the last 5 years, we've been working those facilities through finding new owners, and we completed the sale of the last of those nursing facilities earlier this year, earlier last year. I think it was in June, or over the summer. But that was a long runway to operate those facilities until it was ready to be sold, and then finding owners for them. Lots of work around the backlog that was related to the public health emergency. You can talk some more about that. If you followed the other slides and the number of positions that we have and how many are filled, we have a vacancy problem on our survey team as well, and we've been trying to figure out other ways to address that. All of our nursing facility surveyors are registered nurses, have to be by regulation, but we've been trying to expand that to use licensed practical nurses in some ways and other people who have other qualifications to try to round out the team so we can be more efficient in getting those surveys done. Let's see. And then maybe the last two things I'd just comment on, things that we were assigned responsibility from the legislature last year. Involuntary discharges, we were asked to track the number of people that were involuntarily discharged from their assisted livings or state licensed facility. So we've been working on that since the last session. We've been registering supplemental nursing service agencies. So there wasn't a central place to catalog that, so we've been tracking or asking agencies that provide contract labor to nursing facilities to register with us, pay us a fee so we can keep track of them and then report on what they pay the agency staff and how much of that and what they charge the nursing facilities for those agency staff to try to get a sense of what are nursing facilities paying for labor and what are the actual registered nurses, CNAs receiving from those agencies. So we've had a pretty good 42 agencies register with us, and we'll be able to present some of that data on what we found as we get through in the session. The one that's not on this list is certified, no, I'm not going to get it, Secretary. Continuing care retirement communities. Yeah, I did. I blew it today. So continuing care retirement communities are a special designation for facilities that offer multiple levels of care. It might be a nursing facility and an assisted living, and they do that under one umbrella. And that was a category of facilities that was regulated by the insurance department. Or they wrote the licenses and provided those certifications. We worked with them over the last year or so, culminating last session, to transition that authority to KDADS. The insurance department was doing fine. There were some parts of the regulatory function that they didn't have good visibility on. But we know who's licensed, what kinds of services are provided, and can verify that. We're learning how to look at the financial condition of those facilities. And so I think that's been a pretty successful transition of authority that's happened over the last year, and the survey team did a really great job pulling that off in pretty short order. Just the last couple of slides, not to belabor too much, but we wanted to share some of our stakeholder engagement over the last session. We've done a lot of work led by Lee and others on our team to talk to stakeholders about things that came out of the session, targeted case management, some of the issues that Andy talked about, gathered input on our budget process as well through public meetings, and then try to fit that into our budget requests as well. And then on slide 28, we also had a bounty of legislative reports that we needed to submit. Some are statutory that are on the left-hand side, and things that we've done in the past, but by budget proviso last year, there's another list, makes the list longer, of reports that we needed to produce, and I think we've got all but 3 of those complete and submitted. So those are available for you if you've got an interest in some of those issues. And then last, and some of you have heard this earlier this afternoon, but our legislative priorities, number 1, to move the mental health intervention team program. That was moved to us from the Department of Education and by proviso in the last budget. We'd like to embody that in statute. Our new hospital in South Central Kansas and in South Wichita, we need to get it set up as a state agency so it can have its own budget and we can put the money in the right place, and we'll be ready to serve patients. So we'll present a bill to create that authority. The civil monetary penalty in our state licensed categories, there's a federal program that lets us take fines and penalties and put those into a pool and then use that to provide grants and or pay for some things in facilities to help improve quality. For our state licensed facilities, all of the fines and penalties go directly into the general fund. So we'd like to suggest a statutory change to create dedicated funds for those fines as well and use them to promote quality initiatives or capital improvements or things like that for our state licensed facility types, assisted livings, substance abuse providers, things like that. And then last, to outpatient forensic competency, to make that the default option as opposed to ordering people to Larned. The first place a judge would order somebody for competency is to a community partner, a mental health center, or a provider working for the courts, as opposed to Larned being the first place to go. But we can talk some more about those proposals as they get developed over the session. Mr. Chairman, that's our presentation. Happy to take questions. And if you have some for Andy, he'll come back up too, I'm sure.
Thank you very much. Committee, any questions for Scott or Andy at this point? Representative Steens.
Thank you, Mr. Chair, and thank you, Secretary, for all of your presentations today, all of you. I just had a really quick question. Well, I say quick, it's probably not really a quick one, but on those waivers, I'm still trying to understand all the different ones. You know, I'm familiar with the brain injury waiver a little bit. I know when people get on those brain injury waivers, for instance, that they're on them for quite some time. I know there's an age limit, but so on the IDD waivers, there's such a wait list, obviously. But how do you determine when they come off of those? And do they each have like a case manager? And how does that exactly work? And maybe and like to go maybe to the frail and elderly if they get older or something, you know, I'm just trying to understand some of those. And maybe that's something I need to research and really look into, but I would like to understand those a little bit more.
Yeah, Andy Brown with ks. And I do think that's a pretty big question. So I'd be happy to sit down with you and talk through some of it. But in kind of a short answer, people can only be on one waiver at a time. So if you transition to a different waiver, there's a transition process for that. You also have to maintain services while you're on a waiver. So if at some point you start to not utilize the services for an extended period of time, that can trigger a removal. And if something in your status changes, we oftentimes will have an annual evaluation or something like that. And if there's a change in status, that can trigger someone to come off of the waiver. When you're on the wait list, when you're extended an offer to come off of the wait list and come on the waiver, Then there's another kind of evaluation and check-in and a response time. And if somebody doesn't complete all those steps, they could be removed from the wait list so that we could go to the next person on the wait list and offer that slot to them. Does that make sense?
Yes, it does. And I realize that's a lot, it's a very involved and lengthy or whatever. I'm just trying to understand it because, you know, you look at some of those and you're like, okay, why is there such a long wait list? And how does the process go with some of these and getting some of these people maybe off of these that maybe don't qualify, or maybe they're for something else that would be a better waiver for them, or whatever the case?
Yeah, and we've been having some conversations in the last year or two about different ways we might be able to manage the wait list. Right now, we are not doing things like going through the wait list at a regular interval to see if there are folks that have moved out of the state, for example, or something like that. So right now, there are a lot of names on that wait list that could potentially be removed if we were able to spend the time to go through it.
Okay, thank you so much.
Okay, Representative Carpenter.
Andy, you're being very brief on that one, but I'll just jump in here because it's a perfect segue, because I never miss the opportunity. Anybody in this committee has been here before. I never miss the opportunity to plug the community support waiver, which we've been working on for, what, 2 or 3 years, which is going to come to fruition this next July, which will probably, in my estimation, and until somebody tells me I don't know what the hell I'm talking about, I'm going to say half the people will come off that wait list. And we've had interim committee meetings for 2 years ago, and we have been working on that. Representative Ballard has helped. It used to be close to, oh, I can't remember. It was 5,500 or something.
Yeah.
But anyway, it's not as easy as it might seem. It's very difficult. But to put it in a nutshell, this current waiver provides 14 services. The community support waiver will provide 7, and 7 of the most needed ones that are the most. So anyway, you saw that, you heard it in the governor's budget today, and I never miss a chance to plug that because I'm going to need everybody's support for funding for that, but it's a great thing. But so I'm going to get off of that. These guys do a great job, and I could take the whole damn committee at time and everything else, but it's 5 o'clock, so I'm out of here.
Okay, committee, any other questions? Representative Orpeza?
Thank you, Mr. Chair. I have a quick question for Deputy Secretary Berner. Thank you for your presentation. I appreciate it in this committee. So when you're establishing the new South Central Regional Mental Health Hospital and statute, do you have any plans or strategic for growth, seeing how mental health is becoming quite the needs to be addressed throughout the state? I know it's like 108 beds, but like, what's the plan going forward?
It's 104.
104.
So that grew from about 50. In the original proposal, we started with a proposal for 50 beds over a number of a year at least of discussion. We determined that we could easily support 100 beds in the region just with the capacity that we need. And the limitation will be we've got to be able to staff those 104 beds. But if we assume we can serve all of those, the design of the building, there's not a lot of room left on our site. Actually, there isn't any room left on our site. So we can't expand the footprint of the building any more than what we're going to build in South Wichita. So any expansion down the road, we have talked about once we get this capacity online, and we continue to serve patients across our system, we might think about how patients are served and specialize one campus in, for example, patients that need a longer stay than our standard. We're an acute hospital, so we admit, stabilize, and discharge. Average length of stay at Osawatomie State Hospital is about 14 to 20 days. But there are some patients that need longer stays than that. So we may specialize one campus in that type of service. We've talked about some other options as well. So there may be some shifting in the kind of patient population, but in terms of bed count, we've crammed 104 beds into a site that's going to support 104 beds.
Thank you, Mr. Chair.
All right, committee, any other questions? Okay, so before we wrap up today, I just want to, thank everybody for your time and your attention today. Madam Secretary, thank you. And for those and again, I'm also new to this committee, but we are rapidly approaching, and if you wonder why have stuff scheduled tomorrow, you have to go to February 13th and back off everything that needs to be heard through this committee. And we're running out of calendar to get everything done. So that's essentially it. So it will get better after February the 13th. We do have Budget 101 and I think Pharmacy, Mortuary Arts, Child Advocate, and Kansas Guardianship tomorrow. Thank you so much for your time and your attention. And we'll adjourn and see, I hate to say Friday, but see you tomorrow.